Please join me in welcoming her up to the stage.
Thank you, Mona. So this afternoon we'll take a look at the skin rashes and lesions that can be associated with internal disease. The objectives are listed. I have no conflicts. And some more questions. Necrobiosis lipoidica may be associated with hyperlipidemia, neuropathy, diabetes, or vasculitis. And the second question is graft versus host disease is most often seen after hematopoietic stem cell transplant, transfusion of non-irradiated blood products, maternal fetal transmission, or after solid organ transplants. And the third question is the most worrisome form of cutaneous lymphoma, most worrisome, is mycosis fungoides, marginal zone B-cell lymphoma, follicle center lymphoma, or Sézary syndrome. So because of the frequency of skin involvement in systemic diseases, cutaneous manifestations often prove really helpful in confirming the diagnosis of a systemic disease. And cutaneous disease can actually serve as the initial manifestation of a systemic disorder. For example, here you see that bullous pemphigoid. We often see bullous pemphigoid in the setting of an internal malignancy. So there's a reason that people get bullous pemphigoid. You may see blistering diseases in children that are genetic, but adults just don't spontaneously develop blistering disease without a reason. So we'll look at the different presentations based on the body system affected for this lecture. And the first will be rheumatology disorders. And there are quite a few rheumatology disorders that have skin manifestations. The slide gives the answer away that we're looking first at lupus erythematosus in these young people. But as soon as you walk in the exam room, you know that there's a problem here, right? You know that that is not acne, that is not rosacea, that is not eczema. This is not going to be easy, right? So, and not to mention the fact that those are in cosmetically sensitive locations, and these are actually scarring disorders. So cutaneous lupus or discoid lupus leaves horrific scars that is not easily treatable. But the big question here is it located, is it isolated to the skin, or are we looking at a systemic lupus situation? So we know that lupus is multi-system disorder. It affects Black women far more often, and it affects African Americans at a younger age with a higher mortality rate. So we want to catch lupus as early as we can and treat it as aggressively as we possibly can. So lupus is caused by a genetic predisposition, but it's triggered by environmental factors. It could be ultraviolet radiation or a virus that will then trigger a really complex inflammatory cascade that includes chemokines and inflammatory cell responses and cytokines. And they will target cells that are both within the skin and cells that are migrating to the skin. Subacute cutaneous lupus presents with a photosensitivity eruption. However, the mid-facial skin is usually spared. So that's really important, right? The mid-facial skin is what's affected in rosacea. But in cutaneous lupus, the mid-facial skin is spared. The lesions may be red annular plaques, like on the young woman we just saw, or they can have a more chronic psoriasiform or eczematous presentation, like the young man we just saw. And 70% of patients with SCLE will have anti-Ro autoantibodies. So listed here are medications that are most commonly associated with drug-induced subacute cutaneous lupus. On the left, fairly common medications, calcium channel blockers, PPIs, thyroid diuretics, even the TNF alpha inhibitors like Humira or Enbrel can trigger subacute lupus. Another condition is dermatomyositis. Dermatomyositis is rare, but it's important to catch early. It's another one of these diseases where it's important for us to put different signs and symptoms together in order to narrow down the diagnosis. If you look at those photographs and you look at the one in the middle, you may just decide he's just had a sunburn, right, and nothing particular going on, or that the older woman has some irritation at her eyelids from her eye drops, or maybe that the man on the left has some rheumatoid issue affecting his knuckles. But again, this is one of those diseases where a full body exam, you try to piece together all of those symptoms to try to narrow down the diagnosis. So dermatomyositis is actually a disease of the muscles, right? It affects the proximal extensor muscles, and the cutaneous eruptions may actually just be a precursor to the muscle disease. A full quarter of adult patients with dermatomyositis develop dermatomyositis as a sign of an internal malignancy, most commonly ovarian or colon cancer. And in Southeast Asian populations, there's a predominance of nasopharyngeal cancers. So the signs that we just looked at in those three photographs have names. Everything in derm has a name. Have to have names. Heliotrope sign is the pink-purple eruption at the eyelids. And again, the eyes themselves are not injected. It's just a skin manifestation. Gauthron's papules are the lichenified plaques at the metacarpal, DIP, and PIP joints. And the shawl sign is that photodistributed poikiloderma that we saw at the upper back. And the other sign that's very interesting for cutaneous diseases are actually unusual capillary presentations around the cuticles. They look like hairpins. They have a very sharp U-shaped. If you look at your cuticles, you normally don't see any telangiectasia or blood vessels at all. So to see them in that unusual presentation that you'll see easily with a dermatoscope or a magnifying lens really narrows down that you're looking at a connective tissue disorder. And this is an example of sclerodactyly. So sclerosis is an uncommon autoimmune connective tissue disease that involves a symmetrical hardening of the fingers. Patients may also develop other signs like Raynaud's or even digital tip necrosis, and some will develop flexion finger contractures. But this is a disease that affects not only the skin, but may have systemic effects on the lungs, GI tract, heart, and kidneys. But again, it's a strange thing, right? It looks totally different than just rheumatoid fingers. Those are more common. These, I'm sure all of you see in your practices regularly, the rheumatoid nodules. They are firm, semi-mobile papulonodules, and they favor periarticular areas of trauma. So fingers and hands and elbows are more commonly affected with the rheumatoid nodules. Rheumatoid vasculitis is associated with long-standing joint disease. So patients with rheumatoid vasculitis may actually have the purpuric, like ecchymoses or purpuric retiform patches on their skin before the rheumatoid arthritis is even diagnosed. So the smaller vessels will cause just patches and plaques on the skin, as we mentioned before lunch. Larger vessels or arterial vessels will have more traumatic nodules or ulcers or even digital gangrene. That's a very classic presentation of psoriatic arthritis. Are you all familiar with that presentation? Yeah, so the fingers lose their definition over time, and they just become equally thick, the length of the digit, and actually look like sausages. So psoriatic arthritis affects a full third of psoriasis patients. So please remember that. I'm sure you all see many, many psoriasis patients, and you are appropriately focused on their skin. However, a full third of patients with psoriasis will develop joint disease, and it's a disabling joint disease. It is a lot less difficult to diagnose than we used to think. Oh, they've got to go to a rheumatologist. It's way too complicated. They probably need imaging. Actually, that's not true, and we're seeing that more and more with the new biologics, that our aggressive treatment with biologics won't cure any joint disease that they have already developed, but it will absolutely curtail it. And that's extraordinarily important because, as I say, the joint disease in psoriasis is really disabling. It affects, frequently it will affect the back, hands, fingers, feet, and toes. But an easy test that we're all encouraged to do is to actually palpate and put some pressure on the Achilles in a psoriasis patient. And that in and of itself, if symptomatic, is reason to pursue more aggressive care other than just topical creams and ointments for their psoriasis. So have them seen. You know, if you're comfortable, great. If you're less comfortable, have them seen by rheumatology or dermatology, and patients will be very grateful to be spared that joint disease later in life. So we'll look at a couple of cardiovascular disorders. I did not include the most common cardiovascular sign in the skin, and I was probably remiss because someone asked me to address it. So of course the most common sign of cardiovascular disorder in the skin is when we see stasis dermatitis. So stasis dermatitis develops from long-standing edema at the lower extremities that over time starts to pit and become hardened. You all know if a patient has significant edema at the lower extremities and you put you press your finger into it, the divot will remain in the skin. That's when it's very significant. But patients will have thickening and pressure on the lower extremities to the point where the skin is pulled taut like a balloon. And that starts to break down the elastin fibers in the epidermis. And when that happens, the patients are at very high risk for developing ulcers. And we all know that bacteria flows downstream, so we all have chronic colonization of bacteria of the lower extremities. So when you've got that setting of constant pressure, the skin breaking open, and developing this secondary infection is your big concern. So of course you're always looking for cellulitis. I think the best pearl I can give to the person who asked me about this was that it would be extraordinarily unusual to get cellulitis at both lower legs, right? If you're seeing a rash and an inflammation of both lower legs, you're also seeing post-inflammatory hyperpigmentation. Well, those are big words that simply mean that normally the pigmented cells are in the deeper layer of the dermis. When there's a lot of pressure on the skin, either from acne or some sort of inflammatory nodule or this kind of chronic swelling, those pigmented cells push up to the surface, and that's where you can see the darker pigment in the skin. It's also what causes a suntan. So all suntan is caused by trauma. There's swelling and inflammation in the skin that brings those pigmented cells or melanocytes up to the surface. They will eventually recede if the swelling subsides, like the acne lesion clears. They'll eventually recede back down to the lower layers of the skin, but that can take months and years, and in the lower extremities, that may never resolve completely. So you're always seeing this kind of gray, brown, rough area that eventually turns into very significant lymphedema if that pressure and those fluids are not reduced by exercise, elevation, support stockings, diuretics, and that whole package. So you're far more likely to see that presentation on both lower legs. We call that chronic venous stasis dermatitis, usually accompanied by lymphedema, cellulitis, hot, warm. So it doesn't mean you can't get cellulitis because of your swelling and the ulceration of your skin, but it'd be very unusual for you to have cellulitis that just pops up in both lower legs, right? No. So I hope that answered a little bit. But we'll look at two less common disorders. One is Beckett's disease, or Bechet. Has anyone ever seen Beckett's? Yay, one person. I don't think I have, but it would be easy to miss. I could be remiss. So it's typically there are these chronic recurrent aphthous ulcers, but it is also accompanied by ocular inflammation in the form of uveitis or vasculitis and genital ulcers. So it's affecting the mucosa, right? Eyes, oral, genitalia, and some patients have erythema nodosum that develops on the lower legs. We'll see a photo of that in a minute. Virtually all patients will have the ocular involvement. So I don't think we see this very often in derm. It's probably caught either by you in primary care or by ophthalmology. But dramatically, this is a disease that, as listed here, can affect many body areas and can potentially lead to blindness or very poor prognoses. And Kawasaki's disease, we've talked a lot about in this era of COVID. Kawasaki's disease is a disease that will affect multi-system disorder that will affect children under 5, but it presents with a very dramatic high spiking fever that will last for 4 or 5 days. So the kids are really sick. They will have a myriad of different symptoms, and including or a sign, including the most classic is that their tongues become really injected and they have hyperemia, so their tongues look just like a strawberry. They also have conjunctival injection and a morbilliform exanthem, and they may also develop edema and desquamation at the extremities. There are a number of conditions that are associated with endocrine disorders. You're probably very familiar with most of these, and maybe not familiar at all with some of the less common. I'm sure that you've all seen granuloma annulare on the back of the hand or on the forearm as an isolated lesion. When it becomes disseminated, the lesions are not nearly as dramatic. They're more diffuse, but they are still discretely annular. So it's a little bit harder to diagnose this. This is another situation where if you just step back and you try to describe what you're seeing on her thighs, you would describe it as annular, and you would be hard-pressed to say, well, that's tinea versicolor, because it's not itchy, it's not scaly, and one plaque on top of the other. That'd be kind of a curious person, possible, but curious. So that is a more discrete, more diffuse presentation. And the disease next to it we'll talk about in a sec is called Kyrle's disease. And that also is fortunately uncommon. But what is common is eruptive xanthomas. You're going to see these frequently in diabetic patients. These are the red-yellow papules that'll pop up in clusters pretty acutely over weeks to months. We see it in patients who have poorly controlled diabetes, but once they control their blood sugars, the xanthomas actually resolve spontaneously, so that's nice. We mentioned the disseminated granuloma annulare. That is associated with diabetes, but also with lipid abnormalities. And it's a little bit, well, it's not a little bit, it's a lot a bit harder to treat. We try topical steroids, we try light treatments. At one point, there was a paper that seemed to be promising about using a combination of 3 different high-dose antibiotics. That did not pan out. And the granuloma annulare does not resolve with improved blood sugar. So it's difficult. I've had some elderly patients who are really trying hard to take care of themselves, and they're very uncomfortable going to the gym or going to the pool because people are looking at their skin and thinking leprosy or other foolishness. The Kyrle's disease, we saw the photo of that on the gentleman's legs, it's just awful. It's a very, very itchy, perforating disorders. Those plaques are coming from deep within the dermis. And they're brought up to the surface in patients who have chronic kidney disease, most likely on dialysis, and are seen more often in African American males, but they're not uncommon within that population of chronic dialysis patients. Not good treatments for those either. So acanthosis nigricans, we've all seen, we're all familiar with it. It's been historically associated with insulin resistance. However, there is an acute onset of acanthosis nigricans that will develop very rapidly, and it will be not just that velvety, smooth, hyperpigmented patch, but it will become somewhat lichenified and thickened and develop acrocordons, tags, keratoses throughout, and that is a skin sign of an internal malignancy in about 40% of cases. So very common, a very unusual presentation, but please be alert to that. It seems to have a little bit more of a propensity to develop with cutaneous lymphomas. So we had a question about necrobiosis lipoidica. Has anyone ever seen this? They used to call it necrobiosis lipoidica diabeticum, which just kind of gives the answer away, but they took the diabetica away because there isn't that there isn't that strong a correlation. And there are many diabetics who will never get this. There are many patients who will get necrobiosis lipoidica who don't have diabetes. But it is it's a granulomatous and therefore a scarring dermatitis. And it is associated with diabetes, but it's also associated with thyroid dysfunction. Tends to affect young to middle-aged adults, predominantly female, and they'll get these yellow-brown plaques that will atrophy centrally and ulcerate, which creates sort of a necrotic border that develops. They are very difficult to treat, and they will not resolve simply by improving diabetic control. We're all familiar with the fine, smooth skin and fine, thin hair in patients with hyperthyroid, and we're familiar with the dry, coarse hair and brittle nails and brittle hair and skin of patients with hypothyroid. But it's important to remember that alopecia areata and vitiligo and nail disease can accompany any thyroid disease. So be on the lookout for an association between vitiligo, hair loss, nail disease, and thyroid disease. It's actually quite common. You're familiar with the effects of chronic corticosteroid therapy, creating the abnormal fat distribution and skin atrophy in patients who develop Cushing disease. Of course, they get secondary acne, and many patients will become hirsuite. Addison's disease, which will develop from adrenal insufficiency resulting in low cortisol and aldosterone levels, will cause that unusual dusky diffuse hyperpigmentation. But also curiously, there's a loss of axillary and pubic hair in Addison's patients as well. What about skin signs associated with liver disease? Porphyria cutanea tarda is the most common metabolic disorder, and that develops from patients who have an enzyme deficiency. The deficiency is within the porphyrin heme pathway, and the patients will develop photosensitivity and skin fragility when they're exposed to certain hepatotoxins like alcohol or viral infections. And that's a photo of diffuse lichen planus. And lichen planus we associate heavily now with hepatitis C. So that's one thing that you want to check for right away if you see a patient with diffuse lichen planus. As I mentioned earlier this morning, the 5 Ps, there are actually 7 now, but the most common Ps that you're going to see in the morphology of lichen planus presentation are paritic, so itchy, flat-topped, angulated purple papules, and they often will have that white lacy striae on the surface, and certainly we can see it on the cutaneous lesions and very distinctly on the oral mucosa, those Wickham striae. That was a really traumatic example of lichen planus from one of my patients who had started a new cardiac drug, I can't remember which, and he developed this very traumatic lichen planus response as a drug reaction. So it often occurs at the flexor wrists and forearms, also at the ankles and at the lower back. But we also know that lichen planus will affect the hair follicles, right? That's lichen planus pilaris. It may affect just the nails and cause really destructive nail dystrophy. We mentioned the oral mucosa. The patients who have oral mucosa or genital tissue affected by lichen planus are far more likely to develop squamous cell carcinomas, not because of sun exposure, because of the chronic inflammation in the skin. So important to be on the lookout for new, rapidly growing nodules. Pyoderma gangrenosum is a very painful, uncommon ulcerative disease. And the characteristic lesion is an ulcer that then also develops a necrotic border, and it can become vegetative or purulent in the center. But the important thing about pyogenic granuloma for our purposes is that it is associated with inflammatory bowel disease. So more often associated with Crohn's than with ulcerative colitis, but can also be associated with arthritis or hemolytic disorders. And renal disorders, just look at these two that are fortunately also very unusual. Calciphylaxis is an ischemic necrosis of the skin and the soft tissues that's obviously very painful, and it starts with redness that rapidly develops into retiform purpura. It's associated with end-stage renal disease, patients who are on hemodialysis, but there is also somewhat of an association with liver disease. I saw calciphylaxis when I first started my career in Manhattan in neonatal ICU, and I was, of course, not familiar with this at all, but that was with a young child who was getting chemotherapy, and the chemo extravagated from the vessel, and the entire digit developed calciphylaxis and had to be amputated. So fortunately, very unusual, but again associated with chronic renal disease. The deposition disorders I suspect you see quite frequently. Gout, of course, develops from the development of hyperuricemia and those crystals in the joints. And pseudo-gout will develop from calcium crystals, which more often will develop in knees or larger joints in older patients with osteoarthritis. And there are metabolic disorders that will also be able to clue us into an internal problem. This is an example of scleromyxedema. So mucin is a component of the dermal extracellular matrix. So what does that mean? In the dermis, there are a number of appendices, like hair follicles and oil glands and such, and they are simply kind of swimming in a jelly-like matrix that is composed of complex carbohydrates. So there is, in a situation where there is excess mucin and dermal collagen that develops, in that situation that causes this scleromyxedema, and that creates those firm, waxy papules that develop on the skin, and those are called sclerodermoid. You've probably seen mastocytosis in children. Mastocytosis is characterized by the Derrier sign, and Derrier sign is always a board fodder question. If you rub on the skin with an eraser, and patients who have a hypersensitivity, they will have a sudden relief of mast cell mediators, and those mediators will cause not only a wheal on the skin, but they can cause that kind of internal inflammation where we can see systemic pruritus or flushing or even syncope just from the mast cell. Graft versus host disease is multi-organ disorder, but it does have significant morbidity and mortality. So what happens is that the host antigen presenting cells cause destruction of target tissues in the skin, but also in the liver and GI tract when it activates cytotoxic T cells. It also will trigger natural killer cells and cytokines. And it initially has an unusual presentation in an acral, so from extremity to upper trunk morbilliform or measles-like eruption. But it occurs 1 month after the patient has received a hematopoietic stem cell transfusion or transplant. It can also happen in the setting of solid organ transplant or maternal fetal transmission or blood transfusion, but it is most common in stem cell transplant recipients. And in pulmonary disease, I think you are all far more familiar with sarcoidosis than I. We don't see it that often in derm, but it is a granulomatous disease that you can see affecting any organ system. And it's triggered by the exposure to an antigen that, again, is triggering the cell-mediated immune system. And 90% of patients will develop pulmonary disease. The classic presentation is a yellow-brown papule. If you blanch it with a microscope slide, it will turn the color of apple jelly, which I had to look up is apparently golden color. I don't know, a lot of people eat apple jelly. So anyway, that's always a board question, is what skin lesions are associated with the golden color of apple jelly? It's sarcoidosis. So sarcoidosis is a diagnosis of exclusion, both clinically and histologically. So it is something that is considered really a mimicker of many other dermatoses. So again, you're probably diagnosing it more often in the primary care setting with the secondary pulmonary association than what we are seeing in derm, but there are 3 different very distinctive subtypes that are listed there for you as well. And we mentioned earlier the erythema nodosum. This is an example. So erythema nodosum is very tender inflammatory plaques under the skin, typically tibial, but it can be also in the upper extremities. And you don't want to mistake that for cellulitis. There are usually a number of different lesions. They're very sensitive, and that is associated with sarcoidosis, and it is also associated with flares of irritable bowel disease. It can develop from a hypersensitivity response to bacteria or viruses, but most often you're going to see that with sarcoidosis or irritable bowel. And what about COVID? I was asked about this also. The American Academy of Dermatology has maintained a COVID-19 registry, in order to identify the different cutaneous manifestations of COVID-19. And it seems that about 20% of patients will have cutaneous manifestations, but there's no systematic timing or frequency of the skin lesions associated to the disease. In fact, patients may get a morbilliform eruption or the measles-like eruption, but the ones who get it usually don't get it until a month after they've already had COVID. So it's not very helpful. And I don't think we know why that would happen either. You are certainly all familiar with the COVID toes or the pernio-like lesions, but not only affecting toes, we've also seen them on fingers and lateral feet. And I've seen urticaria in 3 young people this spring with no obvious trigger, and I just did the H1 blocker cutaneous relief thing, and only fairly recently learned that urticaria may be a presenting sign of COVID. You guys know that? Yeah, missed that one. So it in and of itself may be reason to COVID test. Patients will also get less common eruptions, macular erythemas, some vesicular eruptions, some retiform or necrotic vascular eruptions. And I've had one patient develop really significant psoriasis that was associated with her COVID. The timing was perfect, and we were able to treat the psoriasis aggressively just with light therapy, and then she got reinfected with COVID. Psoriasis flared up again, and once she really did resolve her COVID infection, the psoriasis spontaneously resolved. Just very curious manifestations of this disease. And there's some paraneoplastic conditions that we should be familiar with. This is an example of cutaneous T-cell lymphoma, or CTCL. But first, I just wanted to present the B-cell lymphomas. So cutaneous B-cell lymphomas are really, the vast majority are really indolent. They're not an aggressive tumor. They're not scary. They don't become a systemic problem. There are some obscure exceptions to that, notably the diffuse large B-cell lymphoma leg type. Again, in Derm we like names, right? So who came up with that one? That's bad. But these patients only get one tumor at the distal aspect of one leg. That, however, is an aggressive form of cutaneous B-cell lymphomas, but the vast majority are not worrisome and can simply be watched or treated locally. The opposite is true of cutaneous T-cell lymphomas. T-cell lymphoma is a very aggressive, really uncomfortable disease that really affects the patient's quality of life. It starts out with a fairly innocuous-looking eczema or psoriasis presentation, but it advances over years to develop into plaques and nodules. It's extraordinarily pruritic. Patients are extremely uncomfortable with it, and it does have systemic malaise for an awful lot of patients. The most worrisome form is the Sézary syndrome, and there's a very, very poor prognosis with Sézary syndrome, and due to opportunistic infections. So it's very common for us to misdiagnose CTCL, it is a cancer. It's a cancer of the lymphocytes that are being recruited to the skin and not to the lymph nodes, as you're more familiar with normal B-cell lymphoma. But the cutaneous lesions are often misdiagnosed and mistreated as eczema or psoriasis. So just be mindful in middle-aged to especially older patients. It's kind of unusual to just pop up with eczema when you're 70. And if you pop up with eczema when you're 70 and it's not getting better and it's spreading, you may want to start doing biopsies, because it usually takes a number of biopsies over a number of months or years to get the patients properly diagnosed. That's an example of a tumor in a gentleman who has had colon cancer. He passed from his disease. So these cutaneous metastases of internal malignancies is uncommon, but we see it more often in patients with very advanced malignancies. It's most commonly we'll see it in breast cancer or melanomas in women or men who have melanomas, carcinomas of the head and neck, or lung or colon cancers in men. But the lesions are not erythematous, they're not painful. They pop up actually fairly often in the area, the body area affected. That one happened to be on his forehead from his colon cancer, but it is a sign of an advanced metastatic disease. And I just want to spend a minute talking about pruritus, just because I'm sure that you struggle with pruritus as much as you struggle with rashes. Is that fair? Yeah, pruritus is hard. Pruritus is really, really hard. And I guess the hardest part of pruritus is to understand that a quarter of the patients who have pruritus have some significant underlying disease. Atopic dermatitis, by definition, is pruritic. If the patient is not itchy, they do not have atopic derm. So 100% of patients and 85% of patients with psoriasis will be itchy. But look at all the other things. There's urticaria, contact dermatitis, drug eruptions we talked about, lichen planus we talked about, right? Infections can be itchy, infestations, scabies, bed bugs, whatever. Of course they're itchy, and of course pregnancy is itchy. So a whole lot of reasons for people to itch. So we can't just say, it's just dry skin, or take some Claritin, it'll get better. That's an example of lichen simplex chronicus, which is just a lichenification or a thickening of the skin just from constant rubbing and scratching. And of course, when it's on your lower legs, you don't bother to bend over to scratch. You scratch with your heel, but if your heel has athlete's foot, then you're scratching the fungus into the shin, and I've seen that too. It's not good. So pruritus is a common symptom of these chronic secondary itch scratch. So not only lichen simplex, but also prurigo nodularis. It's just the exquisitely itchy bumps that the more people scratch, the thicker the bumps get. The thicker they get, the more they itch, the more they scratch. And there's no easy treatment for that. We said that it's also associated with malignancies. Autoimmune disorders, of course, the bullous diseases are very itchy in and of themselves. But as I said earlier, they may be a harbinger of a internal malignancy that is also pruritic. And of course, the chenodermatoses, rare, but they're also very itchy. And then there are non-derm conditions that lead to itch. So exogenous things like exposure to fiberglass or even water, right? I had a lady come back from the Caribbean who couldn't stop scratching and nothing but the water triggered it constantly. We've talked quite a bit today about the itch that's associated with renal disease, liver disease, and thyroid disease, yes, and then unusual exposures like fiberglass, you're all familiar with that. So all of these dermatoses will be associated with itch. If you diagnose this, your patients are going to think you are brilliant. It is the best. So notalgia paresthetica is just a smooth, ill-defined, hyperpigmented patch on the skin. And it'll be at the upper back or it'll be at the dorsolateral forearm. And you can't feel it. You can just see it. But the problem is caused by a pinched nerve. So patients who have this profound, insatiable itch in those locations have had some sort of nerve impingement, fell off a ladder, fell off a horse, a motor vehicle accident, whatever, and it has pinched a nerve in the T2 to T6 area of the back or at the forearm. And that is not resolved just by rubbing creams on them. That is better addressed by sending the patient to physical therapy or chiropractor or yoga once you've done some imaging. But that's not a skin thing, that's a neuromuscular thing. Of course, older patients and patients with chronic xerosis will be extremely dry and itchy. And the last thing that I'd like to just mention that unfortunately you're probably very familiar with are these psychodermatoses where patients have self-inflicted itchy trauma to their skin. Patients who have anxiety or depression or psychoses will often start going after their skin. And probably most of you are too young to know what a matchbox is, but before lighters, there were matches. And matches were a little piece of wood, a little piece of carbon at the end, and they came in a little box. So you never know that anymore. So patients who are as old as I am would collect their little matchboxes, but they will collect in their plastic baggies, and they will bring their little skin specimens to you, and they will be convinced that there are infestations even when there are not. And there are patients who will be convinced that there are fibers exuding from their skin, and therefore they will continue to dig and scratch trying to pull out those fibers. Those are very classic conditions with names, delusions of parasitosis and Morgellons disease. Again, the worst thing we can do is to just say, yeah, no, it's not, because then we lose all rapport. And these are patients who become professional patients, and they shop from one of you to the next, and then they go to one dermatologist to the next, to the next. There are some FDA treatment approved, but not always very effective because of side effects. But there are also chronic, more mild conditions, that people who are constantly ticking at their fingernails or licking their lips. We see children under a great deal of stress will literally rip the hair out of their head. These are all cutaneous manifestations of something going very wrong internally, and I'm sure you deal with that on a regular basis. So let's just look at these questions. Necrobiosis liboidica may be associated with diabetes. Again, it's another sort of trick question, not on purpose, because it's also associated with hyperlipidemia. But those are those very thick ulcerated plaques on the shins of the young women that are so hard to treat, and they'll continue to scar as time goes on. And the next question was the graft versus host disease that is most commonly seen after stem cell transplant, but it will also be seen after transfusion, maternal fetal transmission, and solid organ transplant. And that's that morbilliform eruption that starts at the acral extremities, comes to the trunk, and in stem cell transplants, it's literally a month after they've had the transplant. And the last question for the cutaneous lymphomas, remember we said the B cells, with rare exception, are not particularly worrisome. Cutaneous T-cell lymphoma is more worrisome. The majority of T-cell patients have mycosis fungoides, a very small 5% have Sézary syndrome, but that is associated with a very, very poor prognosis. Thank you very much.
Thank you so much for that great presentation, very informative.
Thank you.
We did not have any questions came, on the platform. Does anyone have anything here? We have time for a few.
Is there any relationship to bullous pemphigoid and diuretic use?
Not to my knowledge. Not to my knowledge. Have you seen a case?
Yeah, I mean, I work in cardiology, so I do a lot of diuretics, and I've had a couple of women, heavier set women with chronic, edema situations, and they developed. So I just didn't know if there was a tie.
Is it bullous pemphigoid or pemphigus? Bullous pemphigoid. It is it can be, as we said, it can be associated with an internal malignancy, but it can also just be an expression of inflammation. And curiously, a lot of bullous pemphigus patients can be easily treated with a tetracycline. And they don't need systemic immunomodulators. Just a course of doxycycline will often keep the disease at bay. So it may just be a reflection of inflammation rather than malignancy.
Yes, I do.
Great. Thank you very much.
Okay. Oh,